Hi, welcome to this evening's event. My name's Nikki Mitten and I'm a brand manager at Colgate. I'd like to welcome you all to this evening's event and those of you who are joining us via live stream. We have two very fantastic speakers with us this evening who I know you're going to find very interesting. We've got Eric Rooney, who is Deputy Chief Dental Officer for NHS England, and Rima Hamad, who is a dental practitioner at Windsor Dental Practice in Salford. The aim of tonight is to provide you all with an overview of how you can be ready for prevention, including a review of the learnings and direction of travel of the current dental contract prototypes. I would first like to welcome Eric to the stage. As I mentioned, he is Deputy Chief Dental Officer for England and is here this evening to help us all to understand the development of contract reform. Eric.
Okay, thank you very much for that introduction. Nice to be here. I see some familiar faces in the audience here, and welcome to those who are on the live stream. So, what I'm going to talk about this evening is, first of all, a little bit about our population and the policy for dentistry and health in general going forward. The clinical pathway that we developed within the pilot program, the learning from the pilots, and then something about the current prototypes. We've just finished doing some evaluation with the prototypes, but we're going to be exploring that with those who are involved in those in some engagement events over the next 2 weeks or so. And so the detail of that I'm not going to talk about tonight because it's only fair to discuss it with the participants first. So if we start with something about the population and our approach to health and to oral health. As you know, we do surveys of the population, the Adult Dental Health Survey and the Child Dental Health Survey, which happens generally every 10 years. And in the last Adult Dental Health Survey in 2010, this chart here just shows what our population looked like. There are 3 parts to it. First of all, right hidden down here at the bottom is the people who have no natural teeth at all. And if we go back a number of surveys, these surveys started in 1968, then that section there would have been a massive big dark blue section here. So people are keeping their teeth for longer and less of them are edentulous. And if you're in practice, I'm sure then you will have experienced that. The second group are those who are, as it says here, less healthy. And that's this group here. And along the bottom, we have the age of the population, and up the side, some numbers for the population. And you can see that the bit of the population which is less healthy in oral health terms, there are some detailed definitions of those in the report if you want to go and look at it, but you know what I mean by that. They tend to be above this age group, gradually increasing. Obviously, at very young age, everyone's healthier. Gradually, people do acquire various dental diseases through life, but the peak here, sort of above 45, 50, and onwards. And the healthier group is this light grey coloured here. Now, what the researchers did in 2010 was make some projections based on the work which had gone before, the previous surveys, and the picture looking forward to 2030 is expected to look something like this. And you can see that this less healthy area here has moved towards me, if you like, i.e. in terms of the age of the population going forward, it becomes more crowded with the less healthy people in the older age group and a far, far bigger proportion of the younger age group with what would be described as healthier mouths. And if you're into making full dentures, then this tiny little sliver down here is all that's predicted to remain of that group of patients. So quite a considerable shift in the health of our population. We need to bear that in mind if we're thinking about our policy for health and services going forward. So that sounds like a very rosy picture, and to an extent it is. However, if you dig deeper into the document, then you'll find that although the adult population's health is changing, then the people who do have their retained teeth, only 17% had healthy periodontal tissues, and only 10% had what was described as excellent health. And the definition of that was 18 or more sound, untreated teeth, no decay, no pocketing of 4 millimeters or more, no loss of attachment, and no calculus or bleeding. So within that, there are still problems in terms of both perio and caries which need to be dealt with. And I think our overall approach to that, as you'll see as we move through this, is to try and prevent as much of that as possible. So that's our adults. You will have heard lots, I'm sure, about children in the press, number of children having general anesthetics and those sorts of things. This is the survey results, again, over time for our children. And you can see here, way back in 1973, which is where this first starts. Children's surveys are every 10 years as well. 1983, a massive drop down here. And then actually a pretty steady approach up until 2013 for the 10 yearly surveys. And then these are the more frequent surveys which are undertaken by Public Health England. And again, you can see from 92 onwards, a relatively stable position, a little bit of a drop perhaps. And then we changed the way we measured things, which is probably why this first drop is here. But thereafter, these are consistent measurements, and you can see a continuing decrease here. The received wisdom of most people who've looked at this is that the big impact here is related to the introduction of fluoride in toothpaste. That coincides pretty much with the time when that happened. We're not really sure about this, but the speculation is it may have to do with the reformulation of children's toothpaste to include higher proportions of fluoride based on the evidence which is in, and the guidance which is in delivering better oral health. So that's what's happening with our children. In terms of our population overall, again, you don't need really to do lots of surveys or look at the statistics to know this is happening. Our population in general is living longer, and we are an aging population. So again, if you look at this, males and females on each side, the darkened areas are the current population, 2012, and the line on the outside is the expected population in 2037. And we've got two areas that we need to be mindful of. The first and the most obvious one is this one here, which is the big bulge. 70 is the age there, the big bulge in population that we will have in this space here and here. And secondly, in this gap here, associated with youngsters. So our population as a whole is changing, and when we think about our services and how we care for them, bearing in mind what you now know about the potential oral health aspects, that's what we need to build our policy and our services on going forward. And it's even slightly more complicated than that, because this diagram here shows life expectancy. And you'll know, I'm sure, just out of interest, that we've got here along the bottom the least deprived people at this end of the population. Sorry, the most deprived, I beg your pardon, and the least deprived at this end. And so life expectancy is lower for the more deprived population, and for the best and well-off, then they tend to live longer. And that's a statistic we've known for a long time. What is really quite important about this, though, is that the life expectancy here is to do, the two lines are to do with disability-free life expectancy, yeah? And you can see that we're expecting people to live for the last whatever that is, and it varies ever so slightly from end to end here, between 10 and 15 years towards the end of their longer life, where they have some degree of disability, which would require some sort of social support or some sort of help. Now, if you put that together with an increasing elderly population who are going to need support in their latter years, who also, from the previous statistics, now have their own natural teeth, which may well be filled with the work that we've done on them. They may have crowns, they may have bridges, they may have relatively straightforward amalgams. But the minute that they enter into this space here and become frail, require support in various ways, then their oral health is likely to decline unless we get our daily prevention that presumably they've been doing in their earlier years up to scratch. So in terms of dealing with this, because the consequences of not doing that are quite difficult to deal with in terms of having to do operative care and whatever in this group here. If we can do prevention for these and keep them with healthy teeth through this period, then that is obviously going to be a much better approach, both for them and for the health system. Now, picking up that general theme, the other thing which is driving our policy at the minute is the NHS plan, which is called the 5-year forward view. And I've just picked out some quotes there that show, I think, that what we're thinking about in dentistry is exactly what the big health system is thinking about in terms of how it's going to manage to provide care for our population, given these population statistics I've just shown you. So the first thing they say is we want to focus in general on prevention, a radical upgrade in prevention and public health. And the second thing, to try and get people to look after their own health conditions as much as possible for themselves, rather than being reliant on having to use health services, doctors, district nurses, all those kinds of people. So there are programs, people with diabetes, people with other long-term conditions. There are programs to educate them about their disease, help them to recognize their own symptoms, help them to self-medicate and keep themselves well rather than be reliant on the system. And you can clearly see the parallel there with our approach to improving oral health through all the things that are in delivering better oral health. And the mechanism by which we want to try and do that for the whole population is through giving patients that empowerment to be able to do that. And you'll see, if you don't know about the contract reform and how that program works, that is exactly what we're trying to do as part of the oral health assessment, is to pass over to the patient and help them take some of that responsibility for their oral health on a daily basis themselves. And we do that by giving them better access to information, both generic information and information that relates particularly to them about their own condition. And as professionals, we need to help support them then to do those things on a daily basis to look after themselves. So that's one of the broad principles in the 5-year forward view, and our program is absolutely in tune with that in terms of policy. The other thing that the 5-year forward view makes quite a lot of mention of is if we're going to do things to people in a health sense, then we should do things that we know work and that are effective. And I just put this up because it comes up in the Delivering Better Oral Health sections that you'll be looking at later on. Just as a reminder that we do have a good evidence base and we have a structure for assessing how good our evidence is in terms of the prevention that we are suggesting, both in the pilots and in general prototypes rather, and in general practice. And as you'll see, that's scaled from 1 to 5. There is also, of course, good practice. Some of our things are the best kind of wisdom that we have over years and years of doing things. They're not desperately evidence-based, but nevertheless, we think they are the right thing to do. So what got us to this point in terms of a changed way of looking at how we deliver our services and what we do? Well, of course, you all know 2006, the current contract that we have, wasn't met with you know, rapturous applause amongst the profession, and as a result of various moves by the British Dental Association, by MPs and various others, there was an inquiry in the House of Commons, and the government's response to that was to set up an independent review. And Professor Jimmy Steele from Newcastle was appointed as the chair of that. And partly, I guess, why I am standing here now and all the things I've done over the last number of years is because I was also part of the group of 4 people who put that report together. So we prepared that report, and the new government, which had just come into play, the coalition government, looked at that and said, yes, seems like there's some good things in there. We need to do something about our current system. Let's do some pilots. And the reason why the pilot thing is there in that paragraph is because there was a lot of sensitivity about the fact that the 2006 contract hadn't been piloted in the way that it was implemented. So the principles which we started with, and which, to be fair, have really come all the way through since that time. And I know many people think, oh gosh, it's such a long time, isn't it? And it is a long time, I realize that. But there is a will amongst the successive governments that we've had not to go down the 2006 route again and jump to something if we don't think that it is actually going to work and it's going to be ready and it's going to be acceptable. So at the heart of it is the preventive clinical approach that we'll be talking about through the rest of the evening. Something about measuring quality and setting up the remuneration system or the commercial side of things so that it supports prevention as well as treatment. And it helps support you to deliver the things that you've been taught at dental school if you've been there recently, and the things that Delivering Better Oral Health says and our professional societies say in terms of the way that we should deliver our care. So piloting began in 2011 to test not a particular mixture of these things, but a number of different aspects that might be brought together to create a contract in the future. So if I move on to what some of those things were, I'm really going to focus tonight particularly on the clinical pathway aspects. So if you've looked in the independent review at all, and it's available still online, then you will see this diagram here, which basically sets out what our view of the population was and how we ought to go about trying to improve things. So the first thing is that we recognize that people come for 2 reasons, really. One is for routine care, people who buy into coming regularly to the dentist, and they buy into the idea of investing now for benefit in terms of health benefit in the future. We also recognize that there is another group in the population who tend not to have that philosophy and who tend to only access services when things go wrong. Obviously, some of the people who are routine people do turn up for urgent care, but by and large they have a different mindset. And we know that people move over time in terms of their lives, various points in their lives. They may be in the left-hand side of this picture, or they may be in the right-hand side. For the purposes of tonight, we'll concentrate predominantly on the left-hand side as you look at it here. So what we said was, what we need to do first off is make sure that we afford the opportunity for people to have a proper assessment of their oral health when they come in. So both they and us understand exactly what their problem is. I think, you know, we can all look back to a long, long time ago when caries was rife, and you know, extractions were the order of the day along with making dentures, and simply having a look around, identifying, you know, that one's going to come out, that one's going to come out, that one's going to need a filling. And that was really kind of the approach that we took a long time ago. We wanted to move away from that to a proper assessment of oral health. Once we knew what that was, to focus on disease prevention and management of disease that was there. So that, of course, would involve treatment of certain things, but with a view then to ensuring that there was secondary prevention to stop whatever the problem was from coming back again. So thinking about recurrent caries and those sorts of things. The next step then was to have some degree of continuity of care. So to think about planning for people rather than in small bite courses of treatment or episodic care, to think about it much more in terms of the lifetime of that person and what they would be going through, and trying to keep that relationship and keep that that good oral health that everyone starts off with as long as possible. And then there is a very, if you look at this carefully, all of these are blocked arrows here, except for this one, which has a little white break there and there. And that was intended to say, really, we shouldn't be going on to do advanced care, and we've got lots of opportunities to do that now with technology and everything, if we haven't got the basics right, and we haven't got an oral health environment that is going to sustain whatever the fancy piece of dental work that we're going to put into the patient's mouth. So that was the reason for that subtle little bit. So that was the overall pathway we were trying to get people to follow. And we had some guidance to support various bits of that pathway. So for example, the disease prevention bit, we had delivering better oral health, and for the appropriate time for people coming back in that continuity of care cycle, we have the NICE guidelines. So there were some bits of evidence, going back to the idea of our pathway should be evidence-based. We did have some bits of evidence on which to build our pathway. But there were also some bits missing, and there were some approaches and guidelines missing to this approach. And in particular, the oral health assessment area, which I've highlighted there. So what we went on to do with a group of general dental practitioners, some academics, some NHS commissioners, and some members of the public represented through the public-facing Health Watch type organisations, whatever. We got everybody in a room and we said, okay, so if we all agree that this is the broad direction of travel, what do we need to have in that oral health assessment? And this is what we came up with. Now, that looks like a very busy slide because it covers a lot of things, but the good news is it's all in one place. So some of it you'll recognize if I just talk you through it. I'm going to do this at a fairly high level, and then in the second talk, the practicality of delivering this is going to be gone through and explained. So over on the left-hand side here, we have our patient assessment, and these little dots just represent all of the information that we gather when we do any kind of examination or assessment. And the little C and the little P indicates clinical factors, and the other indicates, the P indicates patient factors. So we've got clinical factors and patient factors that we gather when we do a medical history, do a social history, any of those sorts of things. And the combined group, obviously there are hundreds of conditions that we have in dentistry, but if you look at the ones which occur most frequently and the ones which were at that time were on the increase, then we decided to slim down just to 4 key areas, and that's those 4 domains: caries, perio, soft tissue, and by soft tissue we were really thinking mainly about oral cancer, and tooth surface loss. And tooth surface loss was epidemiologically on an increase at that time, which is why we chose it. So you can imagine, for each of those clinical domains, there are things that we pick up clinically when we do our examination, which are important in terms of that. For example, in caries, that you've already got some active caries or whatever, or in perio that you've got bleeding when we do probing. And then there are some patient factors, so the behavioural things around the patient. Do they use a fluoride toothpaste? Do they brush the teeth at all? Do they drink 10 cups of tea a day with 6 spoons of sugar in them? So those things which are in the social history have a bearing on each of those 4 domains. And they're different things. There are specific things related to perio that we pick up in the medical and social history. There are specific things related to caries. And there are specific clinical diagnostic tests that we use. So we worked out what each of those were for each of the 4 domains, And then we, on the basis of that, allocated risk to the patient, and in a simple way identified that as a red, amber, green risk category for each of those four clinical conditions. And the advantage that we had then having the Delivering Better Oral Health is that it sets out some patient actions and some actions for the dental team to undertake. And it also talks about risk, so for children who are at risk, etc. It's not quite as explicit as red, amber, green, so we had to make some judgments about that as a group. But we came up with in effect, the logic or the algorithms that would take you from whatever you think the risk is for the patient into the actions in Delivering Better Oral Health. And also, you will know that the NICE guidelines also talk about recall being based on risk as well, and it talks about high risk and low risk patients there. And those times then are just meant to illustrate that you would then set the recall time or the review time based on the risk of the patient. So in a nutshell, that's the clinical pathway that we use, and it's been consistent all the way through with one or two minor tweaks and amendments since the beginning of the program. Just going back to this idea of giving the patient information, helping the patient to understand what their condition is, and advising them, particularly about and trying to motivate them over their own preventive daily actions, then along here at the bottom it says self-care plan, preventive and treatment plans. So in the early iterations, and some of you, if you've been involved in the pilots, will know about this, the software companies created a sheet which, when you got to the end of this process, you could print it out and you could have a discussion, or you could show the patient on the screen. You could have a discussion with them about what their risks were and what their actions were, and they could take that away with them. That was the idea, to help transfer or get them to take some of that responsibility for improving their own oral health themselves. So just to explode this for one of the domains so you get an idea of how it works. Basically, from a caries perspective, your mouth, you've either got active caries in your mouth or you don't have active caries in your mouth. If you don't have active caries in your mouth, then for us that seems to be good evidence that you're, at this point in time anyway, your risk is low of getting any more, especially if it's been like that since the last oral health assessment. But if you do have active carious lesions, then or early demineralization, then we consider that to be at high risk, because clearly whatever is happening in the behaviors you are undertaking or the conditions in your mouth means that it's capable of supporting the development of caries. So there must be some risk of further development. So from a clinical perspective, if you look at the clinical factors, then really you can only be one of two things, either high risk or low risk. If, however, you are low risk and green, it is possible that some of these factors here, patient factors, may modify your risk, which is how we get to our amber category. So for example, if you take frequent sugar intakes or you don't use a fluoride toothpaste, then that would elevate you from a green risk into an amber risk. And I've already said all of this is then mapped to, that's the old version of Delivering Better Oral Health, because this is an old slide, that you can then discuss with the patient. And I suppose the final thing around the overall pathway is that this isn't just about oral health. Whilst these two things, in terms of smoking and alcohol, both have relationships with our oral diseases, and that's primarily why we are interested in them. In terms of our contribution as health professionals, not just dentists, health or dental teams, health professionals, then if we are able to encourage someone to drink responsibly and reduce their alcohol intake to below the levels that are recommended, and if we can encourage anyone to stop smoking, then actually we're doing them a much bigger service than just improving their oral health. And we're doing the NHS and our health system a bigger service as well, because we know that those two things are two of the key factors that drive up the costs of our health service in terms of heart disease, heart disease, and the other big killers, cancer. So I hope that's given you a bit of a background really to the clinical pathway, and the detail on implementing that we're going to hear from you in a wee while, Rima. That's correct, isn't it? So to go to the learning from the pilots. So this is the pilots, not the prototypes. As I said before, we've got some more recent data, but it's only fair to share that with the people involved in the first instance. So the learning that we've got, first of all, based on the red, amber, green scoring and the risk, this just shows you the kind of population that we are dealing with. And we've no reason to suspect really that if this were to be rolled out on a much wider basis than the pilots that we had and still have as prototypes, that the general population profile would be very much different. What we've got here is the age, again, along the bottom, and what we've got percentage up the side. And as you might expect, when someone is very, very young, then really, you wouldn't expect them to have much perio risk if they don't have any teeth. And when they do get their very first teeth, very, very other little risk. The thing, and it goes back to the modifying factors here, the amber part that makes up the rest of this green for the very, very young is related to those modifying factors. So you could imagine a child who is born with some congenital abnormality that means that they are at risk in terms of caries or other soft tissue things, for example, then they would be elevated into the amber category, which is why we've got them at that very young age. And then you can see that the green, as you get older, the proportion of the population who are green gets relatively smaller. The biggest category by far in the adult population is this big amber category. So these really are people without active disease, but with risk factors in terms of lifestyle and their behaviors, which can, of course, be their oral health behaviors. And then the reds here are the risks for caries and for perio. And the light red, so this little red here, this is for caries. It's stacked then with the perio proportion here. And then there's a very, very thin dark line. You may not see it that well from here, but there's a very, very thin sort of double dark line along the top here. And that is people who have both red risk for caries and for perio. And I thought that was quite surprising, because you kind of imagine, don't you, that the people would be who are at risk would be at risk for both caries and perio, but that's not how it turns out. And I mean, I haven't seen any change in this sort of broad picture over the whole period. So we've still got relatively small numbers of people who have risk in both caries and perio at the red level. But the question is, are we really doing any good doing all this prevention and trying to get people to look after themselves on a daily basis and giving them fluoride varnish and all the other things? Well, this is an old slide. It goes back to the first 2 years of the program. But what it does show is along the bottom here, if we look at the adults over here on the left first, this says OHA, oral health assessment. So these are people who were red at the first oral health assessment, or they were amber at the first oral health assessment, or they were green at the first oral health assessment. What the graph shows is what their position was at the oral health review. So at the oral health review, after the oral health assessment, they were all 100% red originally. What happened to them at review? Well, okay, so 50-odd% were still red, fair enough, but the amber portion here and the green portion here are ones who had improved in terms at least of their risk status. Now, some of that, if you think about how we do the caries, some of that is modified by the fact that there was active caries, you've taken a burr to it and you've filled it, and there is no active caries the next time they come back. Well, that will shift them from red into the amber, just still at risk category. So Some of it is, it's not all down to prevention. I suppose that's the message we need to say. But nevertheless, it's encouraging. And you can see the amber, there's not a big shift in terms of the amber. So this would have been, an oral health assessment, this would have been a complete amber bar. There's only a very small proportion went green, and to the wrong side of what we'd be hoping for, a small proportion went red. The reason it's difficult to get out of amber into green is because of some of those things. For example, for perio, diabetes and things like that, uncontrolled diabetes, are risk factors that will put you in amber. And if you've got diabetes, it's not going to go away. So it's difficult to get out of the amber. And that's one of the problems with the red, amber, green system that we're using. Anyway, you can see the idea. So definite some improvement over here, and similar for the children. Only 36% of those who were red originally were red at the oral health review, and 45% amber and 19%. So quite a big shift there. So, and with no data more recently that makes us think that that isn't being sustained through this whole process as we've been going through the pilots. This is a questionnaire that was done to the patients, asking them, compared to their previous NHS care, how do they have a better understanding of what they're supposed to do, what the condition is, and how they're supposed to look after their teeth, or if it was a parent, their child's teeth. And you can see the agreements there, pretty much everything clustered over on this side, and in total 72% agreeing that they have at least a better understanding. In terms of what they actually did, because knowing something and actually doing something are two different things, as I'm sure you've all experienced. This is unfortunately just reported behaviour. It's not. We weren't, didn't have cameras in the surgery, or we weren't, or at home rather, watching what they did. So it has to be reported behaviour. But nevertheless, upwards of 75% over here say that they have changed how they cared for their teeth or their gums. And in terms of how helpful the advice was, so this idea of giving them the information, then 79% overall in the categories which were helpful. So that's the patients. In terms of the professionals who were involved in this, enabling better care to be delivered to patients, provided to patients. So this was asked of the dental care professionals, and there's 320 people took part in this. So that's a mixture of dentists and other dental health professionals. But again, you can see a lot better, a little bit better, about the same, etc. So still, nevertheless, 45 and 37, 82% thinking that actually this is something that enables better care to be provided to the patients. In terms of who was doing this, or in terms of the way of making prevention work in a practice setting, so what we were asking people to do was to deliver that pathway that I've been through. When they were asked about skill mix, what they thought about that, particularly changing skill mix. If they knew for sure that we were going to go forward with this, and obviously that's to do with business and not wanting to make a change and then discover, oh gosh, they've changed the rules again, so I've got to change my way the practice is set up, then if they knew for sure that this was the way it was going to go forward, then 85% said that they would consider changing their skill mix. And that's because many of the elements of that pathway don't require a dentist to do that activity. And in terms of which of the groups they were looking at that time, remembering that this was in the early stages after the first 2 years or so, therapists were the highest level. And I guess that's because they could do some of the operative work as well as the preventive work. But coming along in second place were nurses trained in fluoride varnish application, nurses with additional skills. We have something called interim care management visits, which is really, particularly for perio or for fluoride varnish, you have your oral health assessment, and then you may need to come back, but just for a preventive intervention. You don't actually need a full oral health review at that point. That can happen further down the line. So those interim care appointments, then training DCPs to do that is something that people were keen to explore, and I still hear that now. Of course, one of the difficulties is all bound up with our current courses of treatment regulations and the fact that a dentist has to basically sign for a course of treatment. So there are still problems with some of the way that our regulations that affect the main system affect this system. But use of skill mix is clearly something that practices think is a way of more efficiently and effectively delivering this pathway. So the learning really is that the prevention focused pathway has been welcomed both by the patients and by the practices, and we've done similar questions to this over the period, and by and large the practices are still keen on this as a clinical model for delivery. Some of the pilots during this phase up until just over a year ago were able to maintain access, so able to keep the same number of patients. Some of them lost access, saw less patients for the overall quantum of money that they were receiving. And obviously from a public purse perspective and a value for money perspective, that's not really a sustainable thing going forward. And so as part of the change over into the prototypes, some measures were put in. First of all, a capitated number of patients to be delivered for the quantum of money, and secondly, a reintroduction of some activity measure, currently using a variant of the units of dental activity in order to have an activity measure as well. So a blended version is what has gone into the prototype phase, which we started in April 2016. So the piloting definitely showed the potential for change, and we've moved on to prototyping now. So if I move on to that and just give you the information about what that entails, that's the next section. So in terms of the pathway, this is just a different version of what you've seen before that we've been using more recently. We still have that same pathway: the oral health assessment, then the risk, then the prevention, and then the any treatment that's required, and then the oral health review at an appropriate time. That's still there. As I say, we've made over time a few little amendments, particularly recognizing that not all patients want to follow this pathway. And if people have a discussion at this stage with the patient about what their problems are, and it's clear that the patient doesn't really want to buy into coming back for further preventive things, or even maybe taking away the daily messages, then it's perfectly acceptable for someone to just, you and the patient, to agree at that point, look, this is not the style of approach that's going to suit your care. You know, if you want to go away and come back when you've got another problem, then that's fine. And so we've allowed that to happen. So the prototypes are also, I mentioned the quality thing before. All through the process, we collected some quality measures. There was a quality and outcomes framework in the pilots, but we never used it in earnest. And the reason for that was the data quality was so poor that we couldn't, not because of anything that practitioners were doing or not filling correctly or whatever. It was to do with software and other things. And it wasn't really robust enough to be able to make any payments associated with it, which was the original intention in the first pilots. There are 4 domains in the quality framework: clinical effectiveness, patient experience, safety, and data quality. The patient experience is similar to the DPB BSA questionnaires that all practices get around patient experience. The clinical effectiveness is to do with whether or not you're able to keep patients free of decay, or at least not have them go any worse, and similarly for perio. And the data quality is about the time at which information is sent in. There is a higher amount of information flows between the pilot practices or the prototype practices and the BSA than for general practice. That's because we gather in all that information about the RAG scores and so forth, and we just have a quality measure there to make sure that they actually send that in when it's required. We've not paid on the quality aspect this year. That sounds terrible, like we haven't paid people. That's not what I mean. What I mean is that the proportion of the overall fund that everyone has that was originally intended to be paid through this quality mechanism has just been paid anyway. And I think there is some discussion at the moment really about whether we think we've already got a blended system with activity measures and we've got capitation measures, and practices need to balance up both of those to try and land at the right place at the end of the year in terms of their contract, and to introduce a third variable into that which has money attached to it, we think may well be too complicated, and some of our practices are telling us that as well. We'll still report the quality outcomes, but I think we'll perhaps, when we will be discussing with the engagement events, how we might use that information in a slightly different way going forward. So we're testing a blended model, as I said. So it's got a mix of capitation, so a patient list that the practices are required to keep up, and a number of units of activity. They are slightly different in the way that they're the number of units that are attached to bands 1, 2 and 3 in this program, but a number of activity measures that the practices need to meet. And both of the blends that we have in the mixture, both of them, the capitation is the biggest proportion of the financial envelope or fund. So to illustrate that, there's just a couple of pie charts here. The green part is the capitation part and the blue part is the activity part. So blend A, 60% of the overall fund is associated with capitation. And in blend B, 83% is associated with capitation. And the reason, the way that these are split up differently, is that in the blend A, then all band 1 activity is included in capitation. So capitation accounts for your assessment and your prevention and the kind of things you would normally do in a band 1 course of treatment in general dental practice. And anything that would normally be a band 2 course or a band 3 course accounts in your activity measure. In the blend B, then it's only the band 3 clinical activity that is counted in terms of the units of activity adding up to what you're required to deliver. So everything that's in band 2, so simple fillings and all those other things are included in the capitation bundle in blend B. In both scenarios, because, and I argued from a clinical point of view quite strongly for this, that everyone has an activity measure in their outline contract to meet along with their capitation number. But I definitely wouldn't know whether or not I've got the right number of units to be delivered in here or in here for the population that I have. The number is based on, was for each practice based on history and a few other things. So what we've allowed is for people to move effectively if there's not enough, bearing in mind the stuff about the oral health of the population improving all the time, if there's not enough clinical material, if you like, in your practice population, and you're clearly not going to meet your units of activity in the blue slice, then you are able to shift that over into additional patients. So you can increase the number of patients you're looking after at the expense of doing units of activity, and that's clearly to prevent any potential over-treatment or anything just because people need to make a number which is not necessarily related to their particular population. So in terms of how many we've got 80 prototypes, 77 are high street, 3 are community dental services. if you are in the community dental services, I'll own up now, we've done very little in terms of looking at the data associated with community services, because actually the population and the people that they are treating are really quite different, and we've concentrated on the mainstream general dental practices for this evaluation that we're doing at the moment. There were 21 new sites who entered in April 2016. They all came from the standard UDA GDS contract, and there were 56 former pilots. Some of the original pilots left the scheme at the end of the piloting phase and didn't come forward into the prototype arrangements. In terms of the two blends, then the group is pretty evenly spread, 39 and 38 in each, and within each blend there is also a fairly even spread of former pilots and new prototypes. So the stage that we're at the moment is evaluation and learning, with the clinical lead hat on for this program in the deputy CDO role. Then I chair that group, but we do have a group of others round the table from BDA, CQC, pilot prototype practice and other organisations. And we decided that the key themes we wanted to address were the quality and the appropriateness of care. So are people really delivering that pathway that we've set out? I believe they are, but we need obviously good evidence that they are doing so. So that's what that one's about. Improvements in oral health, I've given you a window into that from the early pilots in terms of how we might do that, looking at improvement in oral health over time in the people who've been through this process. Access and accessibility. One of the problems, like I said, with the pilots was there was no real driver for keeping capitated patients up. We as the NHS didn't look at that and apply any pressure on people to keep their numbers up. We really wanted them to try the clinical pathway and see if we could make that work first. And so going forward, it really is important that we're able to, and this links to the value for money, that we're able to offer a timely service to people, which is the accessibility, and provide sufficient access in the population for people who want NHS dentistry with this programme. And then finally, and probably most importantly for all, sustainability for rollout. And that kind of goes across very much the profession and the business aspect of running the business of dentistry with this approach, making sure that it is sustainable going forward, but also from a taxpayer's point of view, we're all taxpayers, making sure that it's sustainable for the NHS. And the timeline that we have on that is that the prototype system ran through 2016 and 17. We are, and we agreed, and we're in it now, if you're in the programme you know, they're running for a further year, 17, 18. And we are undertaking at the moment what's described here as full evaluation. You know, I'm not sure an evaluation can ever be full. There's so much data, there's so much information. But we are taking it to a point where some decisions about how this potentially goes forward over the next couple of years will be taken. And we will be discussing that with through the engagement events with the practices over the next 2 weeks, like I said. So that's a kind of a fairly swift tour through what has been happening in the programme. But just before I go, clearly, this is a relatively small number. The majority of you in this room will be in general dental practice. And I just thought I'd show you, going back to our theme for tonight, really, of prevention, some evidence for prevention in the GDS. And this comes from the annual dental statistics that NHS Digital produce, based on all the FP17s that you send in. So, and this has been the case for a long time. It is a preventive activity, albeit one that we do to patients. Scale and polish is the most frequent treatment delivered to adults, excluding examinations. The second one, aside from examinations, fluoride varnish was the most common treatment provided to children, with 4.7 million courses of treatment delivered, a 13.9% increase from the year before. So delivering better oral health and the preventive messages are clearly not exclusive to the piloting and prototyping process. In general practice, it's obviously happening too. And courses of treatment, including fissure sealants for adults, increased by 10%, and for children by 6.5%. So the preventive things on the FP17 are gradually increasing year on year. And for me, as a kind of public health person and someone who believes that it's important that we do that prevention, but also that the system, coming back to the pilots and the prototypes, that our system actually supports practices and their teams to deliver that prevention, then for me, you know, things seem to be moving in the right direction. So I set those out at the beginning. I've been through the 4 areas. That brings my session to an end, and I hope you found that useful, and I think we're going to have some discussion and questions towards the end of the session. Thank you.
Thank you, Eric. That was a very interesting and informative presentation. Like Eric said, we will have some time at the end of the presentations for Q&A. So if you do have any questions, just hold them for the second. And for anyone joining on the live stream, you can actually post your questions and we will try and get those as well. So I'd next like to introduce Rima to the stage. Rima is a local dental professional and works in the local dental practice, and she's actually been working in a prototype practice. So she's going to go through how she's been delivering prevention in practice. So Rima.
So thank you very much, Nikki, for introducing me, and Eric for a really interesting and informative presentation. What I'm going to be doing is it may be overlapping a little bit with the themes that have already been covered, but I'm going to be coming at it from a point of view of implementing it in general practice. So what I'm really doing is sharing my experiences of using the system. Just a slight correction, I was on the pre-Steel pilot rather than the current or existing prototype. So the experience I've had was the initial sort of piloting of the prevention schemes. So a bit about myself. I graduated from University of Manchester. My first job was my foundation training, which was at the pilot practice in Salford. I then moved on to core training in Liverpool Dental Hospital, and since then I've held a number of different associate positions. So my experience with treating different patients is quite broad. I've worked in a variety of different places. So initially in South Wales, I worked in an area called Merthyr Tydfil, which I don't know if anybody knows very well, but it's quite a deprived area, so it's got a sort of high need population. It's in the 10% most deprived areas of Wales. I also, in Wales, worked in quite a central place in Cardiff, which was in the top 25, or the bottom 25% least deprived areas. So it was actually a completely different set of patients. And now I'm back in Salford because I couldn't stay away, and I'm back in my DF1 pilot practice. So again, that's quite a high needs area. We're a mixed practice. We've got 11 surgeries, 7 dentists, and we've got 2 therapy hygienists. We've also got quite a lot of dental nurses. The surrounding area is predominantly skilled, semi-skilled workers, and predominantly purpose-built flats for the housing situation there. It's in the top 1% most deprived areas in the whole of England. The index of deprivation is measured against 7 main domains, so things like income, access to healthcare, housing, health, education, and employment. So those sorts of things don't necessarily give us a representation of each individual that we treat and each individual in the area, but it gives us an idea of that sort of postcode and how it compares to other postcodes in England. Like I said, I started university in 2007, I graduated in 2012, and Delivering Better Oral Health was initially published in 2007, so it really has been embedded in my undergraduate curriculum, and it's been with me along the way, so it's formed the basis of everything I've done before I graduated, as well as since. The original was 2007 and it was updated a couple of times. It is a living document, so there are updates online, but the most recently published one was 2014, and that's the one that's further forward on the slide. Something that is mentioned in the toolkit, and something that's really important about prevention, is that we should be delivering it to all our patients. So a traditional method of looking at prevention may have focused on those that we thought were particularly at risk, so those patients that you would categorise as being in the red category. But the DBOH toolkit is really helpful and really thorough. It's quite broad, and it also looks at maintaining good oral health for patients who we would perceive to maybe be at relatively low risk. DBOH, the toolkit, is based on evidence, and that's the most important part of our prevention. So that's the main pillar. And the slide that we saw earlier in Eric's presentation showed us the grades of evidence from 1 to 5. And there's a lot of the interventions as well as the preventive advice that are grade 1 and 2 in there. So it's worth looking at specifically what is grade 1 and 2, but it's a very important component of our prevention. The other things that we've got to look at as general practitioners are patient values and circumstances. As you know, each patient is different. They're not all going to uptake the same message in the same way. They're going to have different motivating factors. They're going to have different needs at different times in their lives and different priorities. So the patient is obviously an integral part of this. And also the third part of this is our clinical judgment. So the toolkit does give us lots of really helpful information, and we can tailor that to our specific patients. So this is what we've already seen, and it goes through the whole process, starting from the patient assessment all the way through to their recall and reviews. Within the patient assessment, we're talking to the patient and finding out more about them. Again, each patient is different, and you're going to find lots of different information by speaking to them. We've got to sort of resist the temptation to look straight in their mouth and start recording our BP and our charting, and really go back to basics. And it's all things that we know to ask. So things in the medical history and social history that will have a huge impact on our patients. Particularly I found, and I don't know if you've had the same experience, but children, there's so much variation in terms of their social history, who they live with, whether they live with one or both parents. Are they with a different parent at the weekend to the weekdays? Do they live with their grandparents? Are they picked up by their grandparents after school? Are they getting sugary snacks then that the parents aren't conscious of? So those sorts of elements and questions are quite important. Another thing is children who are just starting high school, so there's a big change and a shift in their behaviour with that newfound independence, and you've really got to look out for that. Ask loads of questions to get you that information. The risk screening is the oral health assessment when you're actually looking in the patient's mouth. So it's information that we would gather in a normal examination, and we're just looking at it in a slightly different way. So we're looking at caries as the obvious one. And what we would categorise as a red high-risk patient would be a patient who has 2 or more cavities on examination. Obviously, you're doing your BP and you're screening for soft tissues and tooth surface loss. So you're combining all of those elements to really position the patient within those 4 domains. And it's also important to note that sometimes you can imagine them going down one stream of this, so down the caries stream or down the perio stream. But there will be overlap, and there will be multiple streams that the patient can be sitting in at the same time. Once we've got the risk category for the patient, it's going to form the basis of what we then do, and that's in terms of our interventions, but also our preventative advice that we give. And as we've already said, it is all covered in the DBOH toolkit, and I'm going to go through a little bit more detail later on in the presentation on how we communicate that to the patient. Like we said, red, amber and green broadly place our patients within all the 4 domains, and it allows us to communicate to them. And it's quite, although it looks simplistic, that's the beauty of it. It's really simple to show the patient where they sit on the spectrum. Describing a specific dental disease, so if you're going to go through periodontal disease, is really useful, but to say to somebody that you're at a high risk, so therefore we're putting you in the red category, it really brings a message home to the patient of how they sit in this picture. I'm going to go through the domains in a bit more detail. So caries particularly, it's the main one that we'll be looking at. Like I said before, teeth with carious lesions, 2 or more cavities is what we'd put in the red category. Early lesions we've got to look for, particularly in the ageing population, retaining their dentition for longer. Looking at early lesions and root caries, that sort of thing is going to be important. Age, again, like I was saying, there's a bit of a issue around starting high school, changes when maybe people are going off to university, there's going to be a change in lifestyle. As people age, there will be some sort of stages in people's lives where things change. Diet, we have got a screen up here of parent pay, and I don't know if anybody knows about this. I don't have children, so I don't know about this, but I have been shown this, and it's what parents can see of what their children are eating through the school day. So they get a card, or they have fingerprint recognition. They can buy whatever they want through the day, and then the parent gets a sort of full account of what's been going on. Now, this is from a parent who is very health conscious, has kept their children on a low sugar diet through primary school, through their early years, fluoride toothpaste, varnish every 3 months. And as you can see, they've gone off to high school and they have had milkshake almost every day, cookies most days, a homemade biscuit, juice, all of these things through the day. That actually is going to change that patient's risk. So it shows the fluidity of the red, amber, green system as well. Just because that patient has come to see you with a very health conscious parent, no caries at present, this sort of change in their lifestyle is going to push them more into the amber category and is going to change your prevention. Again, it flows right back into DBOH and the advice that we give them. Another thing, again, sibling experience. So if you've got a younger child that maybe doesn't have any cavities, but their older siblings do, something to be aware of and to tailor your preventive advice to that as well. There are lots of really helpful summary tables and guidance tables in the toolkit. This is kind of like a really useful aid memoir that you can have up in the surgery, or you can have it to hand, and it summarises everything that you need to know for all the age groups. As you can see, it takes you through each age and what you need to do and what the patient can do, what intervention you can do in surgery. Some of these interventions, you can use your extended duties dental nurse if you've got one, or a dental therapist, because they don't all need a dentist to be done. As I was mentioning before, you've got the evidence base, so the number 1 to 5 beside each preventative advice or professional intervention. And as we can see, the interventions, the professional interventions on the right-hand column are all grade 1 evidence. So all things that we can do to help patients have all got a really good, strong evidence base. That's more than one randomized clinical trial for each piece of advice or intervention there that we can utilize. So it's really excellent tools that we can make use of for our patients. Again, for adults, fewer professional interventions, but we're carrying on the same messages. So in terms of advice, brushing twice a day with fluoridated toothpaste, things like the fluoride content of the toothpaste. I find it helpful to show patients on the back of a packet of toothpaste, on the back of a tube, just to show them what they're looking for. So when they go out and buy that toothpaste, they're getting the right thing. Things like, again, simplistic messages, but spit, don't rinse. We know that that has a big impact. So just delivering that message to patients, small change in their habits and in their routine is going to make a big difference. Fluoride varnish is one of our interventions that we've got to hand. It's got excellent evidence to back using it, and we can see that you can have up to 37% reduction in caries in primary dentition and 43% in the permanent dentition. So we're getting a big impact from this intervention. The recommendation is twice yearly for children 3 years and above. For those who are higher risk, we can increase that to more than twice a year. Adults, twice a year minimum as well. Fluoride rinses, an excellent tool. We've got to, again, make sure we deliver the message to the patient on how to use the fluoride rinse. A lot of fluoride mouthwashes that you buy from the supermarket or that you can get over the counter, if you look at the back of the packet, it usually says use after brushing. We know that using it at different time to brushing is going to have a lot more impact and reduce caries rate more so than using it straight after brushing. So these things are in DBOH, and if you just communicate it to your patient, it's going to help them go a long way. High fluoride toothpaste on prescription. Again, you want to prescribe this to your patients who are giving you cause for concern or are in the high risk category. The beauty of high fluoride toothpaste is it doesn't really need a change in the patient's habits. They're just changing the product that they use, and they're getting higher fluoride content for doing that. So you're not having to have significant behavior change in order to get significant improvement in risk. One of the changes to the toolkit has been the Eat Well Guide, which replaced the Eat Well plate, and this is helpful for us to demonstrate to the patient in a really easy to sort of look at picture how their diet should be made up. And again, this is about low sugar consumption, but it's also about general health of the patient and what's going to reduce their other health risks. A diet diary is useful, but I don't think a lot of patients will bring them back. You can try using them. I do find it more useful to question patients. So again, particularly children, asking them what their favourite food is, what their favourite snack is, when do they eat, what do they eat straight after school. All those questions can give you an idea of what's going on. And also speaking to patients, giving them lots of sort of almost cues and asking them, does any of those ring a bell to you? Do you have lots of tea and coffee in the day? Do you drink a lot of fruit juices? Asking those questions to see if the patient responds to any of those, and you can then tailor your advice. But by all means, a diet diary is really useful because if you get 2 weekdays and 1 weekend day, you can give them some really valuable advice. So periodontal disease and prevention within the toolkit in terms of periodontal disease, as you can see at the top, is in addition to caries prevention. So again, we're looking at patients who are at low risk as well as those at high risk, and also overlapping between the two domains. There has been a little bit of a change in the toolkit recently in terms of self-care plaque removal being a big change. So showing the patients the best methods. Towards the bottom, you can see where it says assess the patient or parent carer's preference for plaque control, and then decide on what they're going to use and talk them through the best way of using that. So again, it's not necessarily about making radical changes, but small changes to their routine, helping them and tailoring what they already do is going to give good outcomes. Further down, you can see risk factor control. So things like smoking and diabetes. We can't necessarily remove those risks entirely, but we can make the patient aware that that is a risk factor for their periodontal disease and signpost them to services that can help them. Tell, show, do. Again, something that you can do with your patient. I always have a model with a TP brush, and I go through with most patients how to use a TP brush on a model. Most of them have seen them before, but just going through that reiterates the message, reiterates the technique, and just talking them through how they should be best using each of those tools that they already have or are already aware of. It just helps to tie everything together. So what else can we do? So these are all our professional interventions. These are all things that we can do when the patient's with us. So we see the patient 2 times a year, 4 times a year, and they're all the things that we can intervene with and give them helpful reminders. But we do need to support the idea of shared responsibility, so moving some of that responsibility over to the patient. Caries, dental caries and periodontal disease are largely preventable, but they do have a big impact on patients, so they can cause a lot of distress, they're costly to treat, they're timely to treat. So moving that responsibility over to the patient to take ownership of their own oral health is sort of the foundation of the self-care pathway. If you think of the whole year, 12 months, 52 weeks, that's 8,760 hours in a year. If we see the patient 2-3 times a year, 4 times a year maximum, we're getting a couple of hours with that patient. For the rest of the time, they're on their own. So they've got 8,758 hours of self-care. We've got to give them the tools to be able to implement their home care properly and effectively to get the most out of it. We've got to be proactive. We've got to recommend clinically proven, evidence-based toothpaste, tools, interventions, and preventive advice for them to be able to take ownership and for them to be able to implement all the advice we've given them. Whole mouth health, so we're looking at management of caries, but also periodontal disease. So caries, we know fluoride works, but there has been a Cochrane review which has shown that fluoride combined with an antibacterial technology in a toothpaste is going to reduce the risk of periodontal disease as well. So we've got a picture of Colgate Total here, one option, but there is a clinical benefit of recommending this type of clinically proven toothpaste. So where am I today? So the DF1 practice that I've come back to is no longer on the pilot, but we're still using a prevention-focused pathway. So we're giving appropriate advice to all the patients, not just those that we perceive to be at risk. As I said before, there is a fluidity of risk, so patients can move and transition, but also we want patients who are green to be able to maintain their oral health rather than drift into the amber over time. Our patients are continuing to benefit from the care pathway that we're using. We give them verbal advice but also written advice, and there has also been a Cochrane review on giving written advice to patients, and it relates more to actually diabetes and care pathways in diabetes, but it has shown that giving written as well as verbal advice has been shown to improve outcomes in terms of uptake of the message, understanding of the message. So optimizing brushing. We're talking about how to improve oral health, but also why. So for example, if we say to patients, you need to brush twice a day, once last thing before bed and one other time in the day, that's good advice, that's evidence-based advice. But if we tell them why, so if we tell them, you know, the saliva flow is reduced during the evening, during the night when you're asleep, you've eaten through the day, fluoride on your teeth before you go to bed is going to reduce your chance of decay. If we explain to them why we're saying spit, don't rinse, that the fluoride is going to sit on the surface of your teeth, it's going to help to remineralize the tooth, it helps and it gives them a reason for wanting to implement these pieces of advice. So this is our self-care plan that we give to patients. So it's got the red, amber, green on the top on this side, and we circle for patients where they sit. We put the BPE score on the self-care plan for them. I explain to patients, we've scored your gum health today. It's from 0 to 4, 4 being the worst and 0 being the best. If they've got a couple of code 4s, I say you've got 2 areas of your mouth that are code 4. So we're working to try stabilize this and bring those codes down. And if they get one of these every year, they can watch their own progress. And it is a good motivating factor. We put our recall at the bottom as well. So based on their risk, we tell them whether we want to see them 3 monthly, 6 monthly, or annually. 3 monthly, they can be seen by a therapist, so that is a useful way to use SkillMix as well. On this side with all the writing, we've got how you can help and what we're going to do for you. So this is the professional interventions and this is the preventative advice. So we're telling them all the things that are in DBOH in a way that's easy for them to read and understand and digest in relation to their own risk and in their own disease. So this is really passing that ownership over to the patient for them to really fully understand, and it is that written information that's going to make the difference. We've got a similar one for tooth decay, so again we're showing the patients their tooth decay status, how many carious teeth they have with the traffic light system, as well as their recall. And again, same thing, we're doing easy steps, what you can do and what we can do. Some patients will get both. So if you've got a patient that's at high risk, in fact, we give these to all our patients, but if you've got a patient specifically where you want to give them both so you can go through the intervention in detail, you can do both. I will talk my patients through all of these as well so they know what I'm talking about and they can relate back to it. You can also give patient information leaflets, so explanations of periodontal disease or the caries as a separate leaflet, just so there's extra reading material for those patients who want to know more. Public Health England has also produced Healthy Mouths in Adults and Healthy Mouths in Children. It's a document that just goes through, it actually covers quite a lot. So it goes through decay and periodontal disease. It includes some parts of DBOH advice in there, so things like spit, don't rinse. It's also got information on cancer, dental implants, visiting the dentist, and it encompasses quite a lot. So there's one for adults and also one for children. So there's lots of different things that you can have a look at on there, things that you can give to patients or direct patients towards, which again will help them to improve and take ownership of their own oral health. Using SkillMix is really helpful, so I work really closely with a therapist. If you involve the whole team in the approach, if you have extended duties dental nurses, or if you have nurses that you can train to apply fluoride, that's going to be an excellent asset for your practice. We've continued this, like I say, even despite the pilot not being on the pilot anymore. We have defined roles for each thing. So for example, if you have a patient who's at high risk of caries, you'll see them for the initial oral health assessment. The therapist will see them within the same course of treatment in order to stabilize any cavities, bring them back at 3 months, check in with the patient, make sure they've still got enough supply of their fluoride toothpaste, re-prescribe fluoride toothpaste, apply fluoride varnish, see them again 3 months after that. This would be with a dentist for another review. Retake your bite wings. As you get to the 12th month point, you're then looking at the patient's risk. Have they got any more new cavities? Are they stable? Have they been complying with the preventative advice that you've given them? If they have, you may want to move them then to the amber category, give them their self-care plan again and explain that they've gone down from a red to an amber. If you're getting new cavities and similar problems, you'd still give them the self-care plan to reiterate, but explain to them they're still in the red category and how they can move themselves out of it, reiterate all the preventative advice. So your patient is getting seen regularly and you're really utilising the skill mix. Supporting materials as well, so patient literature, the pathways, and things for the patient to take home are all really useful. Again, if you've got samples of toothpaste in your surgery, just show them the back, give them the sample and show them the back where it shows fluoride, and that will help. If we follow all of these principles, we're prepared for prevention for our patients, we're prepared for the shift in the delivery of dentistry, which has gone from diagnose and treat to prevent and predict. So we're getting improved outcomes from our patients by preventing rather than waiting for things to happen and then treating them. It's benefiting our patients' oral health today, and we're promoting the behaviour change for the future as well. It helps patients to take responsibility for improving their oral health care, and we're recommending the right products for them at the right times. The principles of this essentially are the right patients are going to receive the right treatment at the right time for them. So as we've said before, we're not going to get a lot of advantage from providing complex treatment to patients who are at high risk of decay and gum disease. So we know, for example, that the biggest reason for failure of crowns from evidence is not retentive features or anything to do with our preparations. It's to do with caries and perio. Caries is the biggest reason that crowns fail. So if we're not giving patients the right treatment at the right time, we're almost setting ourselves up to fail with our complex treatments. Again, giving patients the verbal and the written, utilising our skill mix, all comes together to provide the best for our patients, make sure that we're preventing and protecting for the future. Thank you very much.
Thank you, Rima. That was a fantastic presentation. And we've now got some time for any questions. If you both like to come up to the panel. So if anyone's got any questions, we've got microphones going around. If you just want to raise your hand, we've got one right over there, girl.
Yes, is the timeline for the contract reform been knocked off course because of the election, or is the prototypes and then the the subsequent reform of the contract likely to stay on course for, I think it's early 2020 or 2021, I think I've heard?
So obviously we had the election. I don't believe it set things off course. It was always the intention to run the first year, which we did, and then we had an interim report just to kind of, or evaluation, just to make sure that there was nothing going absolutely too off kilter that we should really stop the process. And we've continued on through into then extending it into this year. So I don't think the election knocked it off. One thing that is of interest is that the new government's manifesto, the previous government, when we started the prototypes, were silent really on dentistry and oral health and anything to do with contract reform. The current government, their manifesto makes reference to improving oral health, particularly for children, and reforming contracts. So actually, there is probably more political cover for taking this forward now than there was before the snap election.
Any other questions?
Mr. Rooney, could you talk a little bit about compliance with this ageing and degenerating population you're predicting? You know, how are they going to understand, receive, and react to whatever information and clinical expertise we, you know, recommend?
Okay, so I think what you may be referring to is obviously that gap of disability-free life expectancy, etc., may be physical or it may be mental, and people's faculties go, and clearly that's an issue in terms of their daily oral health care, both either from a physical point of view in terms of being able to brush their teeth, or from a mental capacity point of view in terms of remembering to do it or having the cognitive function to be able to do that. So I think it's a really, really important issue in terms of the services that we have. It's testing the whole health system in terms of the type of health and social care system that we have to support that. I think it's probably fair to say that our current social care system for supporting people either in their own homes or supporting them when they're in some form of supported living or an old people's home or a nursing home, by and large oral health is not on the top of the agenda of those places. That being said, whilst we tend to think of that as being where you know, older people end up, actually there's a massive proportion, a bigger proportion, who live independently in the community, either with relatives as carers or with care packages from the health and social care system. So whilst tonight we've concentrated quite a lot on thinking about the individual patient in front of us when we're passing this information over, I did some work a couple of years ago associated with an elders care pathway. It was an international thing. It wasn't a particular UK thing. But one of the important outcomes from that, and it was a group of experts from all over the world, one of the outcomes from that was, and it goes back to your predict point that you made at the end there, whenever we know that someone has, for example, early onset dementia or any of those kinds of things, then making sure that we talk to them if at that point usually they're still able to have that conversation, but then get their family involved if they're the ones who are going to be looking after them, help them to understand the importance of that daily prevention. So that's one way of doing it for patients that you know. From a more public health perspective, as you know, CQC have got some new parts within their kind of checklist in terms of oral health for people in the care sector. So hopefully they will be able to exert some pressure there. And the other thing is that I think we have an opportunity as the dental profession. We're sat here in Manchester, which is at the forefront of what are described as new models of care for the NHS, about joining up health and social care. And I understand we do have dental representation within that infrastructure. In other areas, we're doing it through our local dental networks who are linking in with some of the other aspects of the sustainability and transformation plans. But what that's about is trying to make sure that oral health is on the agenda of all those care packages, and people really understand that, you know, people will end up potentially in A&E or as an acute admission because they are dehydrated, because potentially they've had an oral health problem. So we need to make those connections, and that's part of our kind of policy role, and Sarah Harley, our Chief Dental Officer, is very keen. She has this phrase, you may have heard it, putting the mouth back in the body, and that's not aimed particularly at our colleagues in the dental profession. It's aimed really at doctors and other healthcare professionals, remembering that the mouth is really, really important in terms of having good oral health to have good general health as we get older.
Just from a sort of general practitioner's point of view, even if we don't have necessarily the infrastructure for the ageing population in terms of social care, The advantage we've got as dentists is that we see patients all the time, so through health as well as through disease. So where maybe an aging patient may not access their GP until they're older, until they need them, they'll be accessing our services from a lot earlier on. So we're kind of in a really good position to deliver all these preventative messages really, really early. And we may be able to sustain that prevention for longer if we instill them sooner, as we are seeing patients when they're healthy.
Thank you. Any other questions for Eric or Rima? And anyone on the live stream? I am checking. Haven't had any through so far, but one more over there.
Quite happy to ask another one. Out of interest, how does Public Health England, the NHS, work with companies like Colgate, you know, that are heavily research-based and you know, preventive-orientated? You know, what's the relationship? Are you forced to keep it separate, or is there quite a good sort of ongoing sort of communication between you know, the likes of Colgate and you know, the department?
There's no direct relationship. Clearly, Colgate and other companies produce, they have scientists, they have dental advisors, they produce research, particularly around the products that they are developing, and that comes into the public domain, and we look at that in the same way that we look at any other research that comes from any other organisation, university or whatever.
Anyone else got any, or is everyone really hungry? One over?
Hi, Mr. Rooney. Currently, Diva Manchester is looking at how practices are going to be funded, who's going to own practices, who's going to own the buildings, the goodwill, etc. And obviously, centrally, you're looking at a new contract and how that's going to work out. Can you give us your opinion on how the two things are going to come together?
I think it's a very good question. I mean, Diva Manchester I know a little about, not a great deal, but I know more probably about the general approach that's been taken. And Greater Manchester has been kind of seen as being at the forefront of the whole health and social care approach, the idea of devolution, devolved money, pooled budgets, all that sort of thing, which brings with it then the challenges that you identify in terms of the way that our dental business is currently structured, right through from, you know, very small, independent, single-handed practices, right through to our corporate chains. I don't think it's something that's exclusive to us. I don't know if you've talked to the doctors involved locally here, but I know in the area where I work, the same sorts of ideas in terms of things called primary care networks or primary care home, which is the National Association of Primary Care version of it, are all following a similar sort of approach. And the GPs are challenged as well in terms of their current structures. They've been encouraged to federate into groups of GPs who are able to offer perhaps a wider range of services, able to offer access at more varying times of the week. I think it's a serious question for us as dentistry. Last year, we facilitated a discussion with the BDA just around what the landscape was beginning to look like at that point. We're planning to do that again this December. Take stock, and I think, you know, one can see advantages in terms of being part of an integrated health system, which is what this is all about, and from a health improvement point of view and from a population and public perspective, we really should be part of that. We should be part of that team in any given locality. Going back to what I just said about putting the mouth back in the body, there to support our colleagues, there to make sure that You know, if someone has a dental problem, they're directed to the right place and they're not clogging up A&E or GP surgeries in the evening and those sorts of things. But it does come with challenges for our business model and the way we work, and the appetite of our colleagues in terms of you know, joining up, working more collaboratively, etc. So I don't have a short answer for it. To my knowledge, there is no policy which exists around exactly how dentistry will fit in, and it's something that we've recognised and are beginning to think about and try and work out. And if there is learning from on the ground in Greater Manchester, then we're happy to hear about that and accept that.
Thank you. I think there's another one.
Hi, I just wanted to ask Rima why the practice that you're working at left the scheme.
The honest answer is I don't know.
Okay.
Thank you. I was away because I went obviously off to Liverpool, then South Wales, and I came back and they went on the prototype. So I don't own the practice, so I couldn't tell you why specifically. But they were involved in the pre-steel pilot, and then they didn't join the prototype. Sorry.
Any other questions? Everyone's very hungry now. Okay, if there's no more questions, obviously you can contact us after if you do have any further questions, but thank you both so much for a really fantastic presentation this evening. So we'd like to welcome you all downstairs for some food where you were before with registration. Before you all leave, if we can just ask you all to complete your evaluation form that is in your red folder. And you should also see your CPD certificate in there. And everyone joining us via live stream will get a survey sent out to them tomorrow via email. Thank you.